Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
It's great to be back with you, and hopefully we'll have a good discussion today around the risks of ART. I had to really do a little bit of an update for myself because it's not something that I think about quite as much as I think about inflammation and other drivers of risk, particularly traditional risk factors. But we'll review some historic data and we'll review some very, very recent hot off the press data. So here are my disclosures. Esperion Pharmaceuticals, I think I mentioned this last time, makes a product, bempedoic acid, which is a lipid-lowering agent, and you see Gilead there as well. This is the funding disclaimer, and this is an outline of our talk today. So we'll talk about the epidemiology, just to remind everyone the scope of cardiovascular risk in people living with HIV. And then we'll drill down on these four drug classes as being the most interesting things to talk about in our limited time. And then we'll talk about my approach to mitigating risk when I see patients in the clinic. This is from a review that we have in press focused on cardiovascular risk in women living with HIV, and just summarizes the epidemiologic evidence for an increased risk in people living with HIV versus people without HIV for myocardial infarction, stroke, and heart failure. So again, we're not just talking coronary disease, but talking ischemic stroke and heart failure. Part of that is ischemic heart failure, but part of that is other phenotypes of heart failure. And across the board, appears to be the relative risk in HIV versus without HIV is higher in women than men. And where does this risk come from? I think I've shown this before in other venues. You may have seen it. It really is traditional risk factors. And we believe more and more that persistent inflammation and immune activation are one of the significant drivers of that residual risk, even after you try to adjust for traditional risk factors as confounders of the association in large epi studies. And over time, the risk associated with ART, individual ART or ART drug classes, has really declined compared to 20 years ago. So I like this graphic just showing another way that in terms of where cardiovascular risk comes from, it's the virus that's doing the bad damage and not the drugs. We know going back to the SMART trial that this was the case. But these next two slides, adapted from Peter Hunt at UCSF, suggest that in the START trial, which was a trial of early ART versus delayed ART, there really wasn't a signal for reduced cardiovascular events with early ART. So the question is why? And this graph shown here is a study of small artery elasticity embedded within the trial where they were trying to look at a surrogate outcome. So why was it different in START compared to the SMART trial? And his hypothesis really was that the event rates were higher in SMART, perhaps because the nadir CD4 counts were much lower in that patient population compared to the START trial. And so maybe some of these cardiovascular events are low nadir CD4 count diseases. And we have some other evidence for that, which we don't have time to review. But on a population level, I'll just really want to make this point, and I'll make it again at the end, that when you look at population attributable risk for cardiovascular disease in people living with HIV, at least if you look at NA Accord as North American cohort, it really is the traditional risk factors, cholesterol, hypertension, and smoking that are driving population risk, in part because they're more common than having a low current or nadir CD4 count and elevated viral load. So want that message to be clear. So now that I've said that, let's think about different ART drugs and drug classes. So this was the original analysis from the DAD study published in 2007 in the New England Journal. And they looked at myocardial infarction in this cohort over the years 1999 to 2006. So really kind of the earlier years of combination ART. And the drugs, again, the PIs that were being used at the time include Tenofovir, Saquinavir, Lopinavir, et cetera. And there was very limited exposure to atazanavir, no darunavir use in that original study. So you can see from the graph, again, that protease inhibitors were associated with about a 10% increased risk per year in incident myocardial infarction. And this became cumulative. So your risk was higher as you had more exposure, which is a little bit different than what we'll see with integrase inhibitors or Abacavir later. Here's just another way of showing the adjusted relative rate per year of exposure. So then the same group went back a few years later and ultimately published these data in Lancet in 2018 to look at darunavir and atazanavir once they had accumulated enough person years of follow-up. And what was interesting about this analysis is that it took a different outcome. So instead of just looking at myocardial infarction, which was about 40%, they added stroke, which was about a third, and then revascularization, so any invasive cardiovascular procedure. So that was actually 50% of the events in this study. So it's a slightly different outcome. The time period was different. And you can see that darunavir was associated with an adjusted incidence rate ratio of 1.6 per 5 years. Okay, so maybe similar to the other PIs, whereas atazanavir was not. And you've probably all heard of the speculation at the time, which was, does atazanavir have some effect on bilirubin? And does that somehow, well, we know that it has an effect on bilirubin, but is that mediating some antioxidant effect that is, causing reduced cardiovascular events? It kind of became a moot point after atazanavir use fell by the wayside because of the scleral icterus and other bilirubin issues. So that's the PIs. We can certainly come back and discuss that in the discussion time. But I wanted to show the DAD data on Abacavir, which was certainly controversial for a period of time, as Abacavir use has also kind of declined, perhaps less relevant, but let's review. So this was the original publication in Lancet in 2008, which showed that recent, but not cumulative use of Abacavir was associated with relative risk, which you can see here of 1.9, and for didanosine, 1.5. And among patients with high cardiovascular risk, this translated to a relatively important absolute risk increase for those patients. And there was an FDA meta-analysis of trials which didn't show much. We can talk about those data, but again, in a subsequent publication from the DAD group, they showed that the risk seemed to persist even after the period of their original publication. So their argument here was that this was probably not just kind of a channeling bias, as some people had suggested. So what are the potential mechanisms? People have looked at this. There's some studies showing higher platelet aggregation in patients after stimulation with Abacavir compared to a TDF. There's also a suggestion that maybe there's more inflammation with Abacavir regimens compared to Tenofovir regimens. This was A5224S. Grace McCumsey was someone I worked closely with at Case Western. So the interesting thing, though, is that when DAD went back and in 2017 asked the question, for people who continued Abacavir and DAD after having a myocardial infarction, was there evidence for continued risk for recurrent events compared to people who maybe switched off of Abacavir to a tenofovir regimen? And what they found is that there was no signal for risk of recurrent MI. And so they speculated that given this possible effect on platelets, whether patients who are treated with aspirin for secondary prevention of MI may be protected against the adverse effect of Abacavir. We can also talk more about that if you want later. Moving on to tenofovir, I think this is an interesting study published several years ago now from the VA that showed that TDF was associated with a 30 to 50% lower risk of heart failure. So we're kind of going away from MI to heart failure risk here. And this was contrary to their expected hypothesis that because tenofovir or TDF in particular may lead to kidney damage, that would increase heart failure risk, because we know CKD is so closely tied to heart failure risk. And they found the opposite, actually. So this lower risk, hypothesized perhaps due to this link with fibroblast growth factor, which is linked to phosphaturia from TDF, or potentially lipid effects of TDF having a reduced MI risk. So interesting. As we all know, TDF has been increasingly replaced in general by tenofovir alafenamide. And so just to review this publication of 2 Gilead trials that looked at co-formulated ECF TAF versus ECF TDF, you can see that the lipids were worse with the TAF compared to the TDF. And this was followed in subsequent studies, real life studies of switching TDF to TAF, which worsened lipid profiles, and then switching back to TAF reversed those effects. This is just one of those studies showing the increase when switching TDF to TAF. And it can be significant in some patients. So then, of course, there's the issue of weight gain. And thank you, Brian, for this slide on the ADVANCE trial, just showing that dolutegravir with FTC TAF is associated with more weight gain than dolutegravir with FTC TDF. And both of those are associated with more weight gain than efavirenz. So interesting, I think it clearly is also playing a role in the integrase inhibitor related weight change. So let's talk about this most recent data from what is called the RESPOND cohort. This was the first time I had seen the RESPOND cohort. Seems like it's like the next generation of DAD, but this is 17 cohorts in Europe and Australia, 29,000 total people living with HIV. And what they found, again, published in Lancet HIV just a couple of weeks ago, is that higher ASCVD risk was associated with a higher likelihood of being prescribed an integrase inhibitor, perhaps because people felt that PIs and other regimens may be increased risk. So the composite CVD outcome used in this study was the same as that used in the DAD darunavir analysis, but there were significantly fewer events, so 750 events compared to the 1,157 events in that prior study. And what they found is that instead of like the cumulative risk where it's just 10% per year, what they found is that early exposure, 0 to 24 months, as you can see here, was associated with increased risk, but more than 24 months of exposure was not associated with risk. So it's, I think, a little bit confusing about why this might be, but something to perhaps pursue in more mechanistic studies. So I want to end by just sharing my approach to mitigating risk. And as I said before, first and foremost, it's traditional risk factors, traditional risk factors, traditional risk factors. I think this is where we're going to get the most bang for our buck in any individual patient sitting in front of you. However, if you have done everything that you can here and people are still questioning their risk and the risk of certain ART, then there are sometimes reasons to switch ART. But in my experience, I would have to say that the reason to switch ART is almost always in order to prescribe a higher potency statin, for example, to avoid a drug interaction, rather than simply, I want to reduce someone's cardiovascular risk associated with ART. And, you sometimes get this after someone has a myocardial infarction on Abacavir, should we switch to a TDF regimen? I would say that unless there is a really compelling indication, I would typically just recommend aspirin use. And even for patients who are in a primary prevention situation, they've never had an MI, they may be at higher risk on a 10-year ASCVD risk calculator. With the whole media coverage of the bad aspects of aspirin for primary prevention and the risk of bleeding, et cetera, I think you obviously have to have a shared decision-making with the patient and weigh the patient's individual risk benefit and tolerance for risk, bleeding risk versus MI risk. But I do think that there is a reasonable rationale to say maybe favor aspirin use in someone who's on Abacavir. And then I think we will be developing over the next few years more comprehensive solutions to managing these metabolic effects of contemporary ART and just making sure that HIV clinics have access to the drugs we need to treat lipid problems, that they have access to lifestyle and diet counseling to try to mitigate the effects of weight gain on integrase inhibitors. So look forward to helping Madison Clinic achieve that, and perhaps each in your individual clinics can think about what sorts of solutions work best for you. So I will stop there.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.